Assalamu alaikum and welcome to this presentation on consultation skills and communication with the patient. Actually, this lecture is focused on discussion of the patient-centered consultation. We're going to go through what this involves step by step. It is also an opportunity for you to review these consultation skills we talk about today and to try and implement them into your practice. Okay, so in this lecture, we want to understand the components of a good consultation, look at the patient-centered consultation model, and I will have an afterthought to present to you about different types of knowns and unknowns. The patient-centered consultation is the cornerstone of medical practice. There's a long history within medical practice with different consultation models. And I am not going to go through all of these or any of these models today, except we're going to take some time to discuss the patient-centered consultation. When we talk about doctor-centered versus patient-centered, what I mean is the doctor-centered consultation really serves the serves the need of the doctor only. So the doctor dominates the consultation. They ask direct and closed questions. They reject patient ideas and they evade patient questions. This consultation model is for serves the doctor's need. The doctor sees a patient and they don't see the patient, but they see the case, the complaint that they come to you with, and they do not see and recognize the patient behind this complaint. And once they see this patient, all they have in mind is what is the diagnosis, and this is what the needs they serve. But they do not think about the patient. What are the patient's thoughts about their disease? What do they expect from me? What are their concerns? How can I address them? The patient-centered consultation, on the other hand, they start with open question. The active listening is very important in this model, and it challenges also or reflects patients' words and behavior to allow them to express themselves in their own way. It also explores patients' beliefs, ideas, and expectations so that they can be adequately addressed during the consultation. The biomedical approach is the approach that I see you guys use mostly. It means to take an accurate history, perform an accurate and relevant examination, make a provisional diagnosis, a hypothesis or working diagnosis, and then order and interpret the results of the appropriate investigations. It's about the idea is and the goal is to make a definite diagnosis, and this is the model that most people come out of medical school with. And this is also what I see you guys do when you take histories and see patients. The problems with this approach are mainly in that patients are seen as a disease and not as a person. And the kind of condition of their lives, the psychosocial contact, the socioeconomic relevancy does not actually get any credence in this approach. It is doctor-centered, as I said before. There's the patient's beliefs, feelings, and also opinions are not really taken into consideration or addressed in this approach. The information is not shared adequately, and this model collapses absolutely if there's no physical disorder. And then what happens sometimes, what you see doctors do, if there's no physical disorder and they use this approach, what they do is they prescribe some sort of drug which might not be actually helpful, and they do not believe it's helpful, but they prescribe it because otherwise they haven't done anything for the patient. It does not recognize the importance of nonverbal communication, and it makes this is a big failure. It makes no use of the therapeutic effect of the doctor-patient relationship. In 1952, Bailey coined the phrase "the doctor as the drug," and he recognized with the powerful effect that actually the conversation and the consultation itself has on the patient. So the consultation, the relationship between doctor and patient, has a mostly positive effect on the patient, and can be actually therapeutic. So even in patients who come to you, they come with chronic illnesses. You cannot actually change their illness for them in any great way. But the fact that you're there, that you listen to them, that you acknowledge their concerns, and that you kind of give them support will actually make them feel better and be better and leave your practice a better person, feeling better. So now in the next time, we are going to walk through the patient-centered consultation model, point for point for point. These are 13 points altogether. So I warn you now, they are 13 points altogether, and I will really advise you to, after you've listened to this lecture once, to have a look at just the points in your own time again, so that they can sink in and you can make sense of them. So I'm not going to go through these points now. We'll walk through them in the following slides. So first of all, the patient-centered consultation encourages patients' contributions. And this is mostly achieved by asking open questions, by starting a consultation with an open question. For example, how can I help you today? Tell me more, please. So if a patient tells you something, I have my period has changed, and it's not as it used to be before, then this is not telling you very much. So you have to encourage the patient to tell you more. So you could say, can you describe this to me? What do you mean by this? Could you tell me more, please? You have to encourage the patient to talk also by active listening, so that you tell them you listen. So either by saying right, and so on. And you have to clarify certain points within the consultation, within their kind of speech, that you might not understand. Maybe sometimes you're not sure what they mean exactly. You have to respond. So the doctor responds to the patient cues. A cue is when the patient raises a certain concern that they've come to see you with, but they do not spell it out and say, "Oh, doctor, I am actually worried my irregular bleeding is due to a cancer." They do not say it like that. Instead, they tell you, "My period is irregular and my aunt died of ovarian cancer." So they might make this link, maybe this bleeding is due to the ovarian cancer or something like that, but they do not tell you like that, but they give you a cue that this is what is on their mind. So in that case, you have to show empathy. If they are very worried, you show empathy. You say something like, "You seem worried, you seem upset. This must be very distressing for you." But you can also pick up the verbal cues and address them head on by saying, "You mentioned your grandmother had ovarian cancer. Are you worried that this irregular bleeding is due to ovarian cancer?" And then she has the opportunity to share her thought with you, and you can then, during the course of the consultation, explain to her that really this is not usually a way for ovarian cancer to present. What advantage that has is, if you do not address her cues, she will walk out and want to see another doctor because she feels you haven't really looked at her properly. But if you address these cues, she will understand that you listened to her and that you picked up what she was concerned about. And this will not only make her leave more happier, but also she will trust you and follow your advice. Finally, you have to also look for nonverbal cues, and these can be, for example, somebody might look tired, so you can say, "Oh, you look tired. Is that how you feel? You seem worried. Am I right in sensing that you did not understand me?" If somebody looks at you blankly, you can kind of ask them, "Did you? I feel that you did not understand what I said," and then she has the opportunity to say, "Yes, doctor, I didn't understand a word of your explanation here." Okay. Thirdly, you have to elicit the appropriate or you have to put the complaint they present with into the psychosocial context of this patient. Okay, and this is very important. So you want to ask yourself, what else do I need to know about the person? If we go back to this patient with kind of irregular bleeding, maybe this irregular bleeding interferes with her kind of professional or social or family life. So you can ask her, so what do you do? And she might say, "Oh, I'm a teacher." So is this a how do you handle your irregular bleeding when you when you teach? And she says, "Oh, actually, this is a big problem. I never know when to expect my period, and this makes me feel insecure in front of my class." So this is something that she might tell you if you pick up anything like that and you put it into the context of their lives. It is very important to explore the patient's health understanding. And this is also coined as ideas, concerns, and expectations, ICE. Ideas, concerns, and expectations. This is a very, very important phrase. Why is this important? So when the patient comes to you and she's convinced that her irregular bleeding kind of represents ovarian cancer, she will, if you do not pick up this problem and you do not address this problem, even though you have done an ultrasound scan, you have looked at her, done a spectrum examination, abdominal examination, looked at all the parameters, and you know, oh, there's no need there's no ovarian cancer. If you do not spell it out, this patient might leave your practice worried because she feels you haven't really looked at her concern. And this will make her go to another doctor, or it may make her not come back to you, lose her trust. So it's very important that you address her concerns, and this will she will feel better quicker. You will cure her quicker. You will treat her better in the end. So you can also, if she hasn't said anything, you can also just look if there's any other ideas or concerns her. So what are your thoughts? What are your feelings? What would be the worst fear that you have with these symptoms? Sometimes such symptoms are caused by stress. What are your thoughts about this? These are many different ways to kind of explore ideas, concerns, and expectations. And it is good if you kind of take on in your routine a couple of ways to do that so that you can apply them in your consultations. Of course, you have to obtain sufficient information from the patient to exclude serious conditions or to not miss any serious conditions. So this will include asking some close questions, some specific information from the patient that you have not had from her so far. But you have to be careful at this point. So you do not want to, maybe she has told you in the beginning, my periods are irregular. They come kind of every, I have a period for 5 days every 24 days. So they've come earlier now. In the past, it was every month, every 30 days. Now I see a period every 24 days. And maybe she has kind of told you this. So when you ask close questions now, it's important that you don't repeat the same question that she has already told you, because that will show that you have not listened. And this is one point I see you do a lot, that you do not listen to others that have already asked this question, and you ask it, you say this again. So it's important that you make it a habit, and that you listen to a, a, a patient, and you do not repeat what, as in a closed question, what she has already told you in her open response when you ask her open questions. However, it is it requires definite other close questions. So she might not have told you if she had postcoital bleeding. So you can ask her, have you experienced any bleeding after intercourse? So to make sure that to not miss any hint for example, cervical cancer or the like. So you need to do the relevant clinical examination. You can signpost the patient to that, and especially in gynecology, when you do intimate examinations, it's always important to offer her to have a chaperone as well. It doesn't matter if you're a male doctor or female doctor, you should always include a chaperone in your examination. Then you form your working diagnosis. So the working diagnosis might not be the definite end diagnosis yet. It might not even be an illness or disease. It could be something like stress-related headache or unscheduled vaginal bleeding. At this point, maybe you do not know yet what causes the unscheduled vaginal bleeding, but you have this working diagnosis, and you can look at what investigations do I need, what examination and what investigations do I need to do to kind of clarify this point further. You have to use appropriate language in your consultations, and I know that you are very aware of this point, and this is good. You should avoid jargon. You should always start with the patient. So, for example, if a patient comes to you and she's 10 weeks pregnant, and she comes to you for an ultrasound scan. During the ultrasound scan, then you see that actually there's no heartbeat, and the size of the baby is only 7 weeks. Okay, so it appears she has had a missed miscarriage. So in this case, you have to ask her, what what do you already know about miscarriage? She might be somebody who has experienced miscarriages before, or she might be somebody where this is the first time. So you want to kind of pick her up where she comes from, so that you do not maybe give her information she already is very familiar with and she knows better than you know yourself, but at the same time also you do not want to miss giving her any information she still needs. It's fine. It's good if you can use the patient's own words. So in gynecology, you might find patients come to you and say, I have an infection. I noticed this 3 months ago. And then you ask, so why are you saying that it is an infection? What are your symptoms? Why do you think you have an infection? They will tell you, I have the discharge. I noticed that a change in my discharge, and they equate this to infection. So therefore, it's important that you kind of understand what the patient means by her terms. And in some cases, also important to know what they say and use their words. Chunk and check is actually a technique that I like a lot. It means that instead of if you, for example, want to explain to the patient miscarriage, you do not give them a 10-minute spiel about miscarriage, but you give the information in little chunks, and then you check that they understood what you have said. In this way, you avoid them at the end to kind of being all confused. Checking patients' understanding does not mean that you talk to them for 10 minutes and at the end of you just say, is this clear? And then the patient said, yes. This is not enough. You really have to kind of check that they know it on the way as well. You have to give opportunities for questions, and at the end, before the patient leaves, you want to summarize your consultation. So in this summary, you want to put the most important points of what was your diagnosis, how are you going to treat it, and when are you going to review the patient. Another important point is to confirm the patient understanding. So the patient might say, yes, I understood, but she might have understood completely different from what you intended her to understand. Therefore, it is important that you check if the patient, especially to check that she understood what you wanted her to understand. You can do this in many ways that you can, and you can say, oh, I know this was a lot of information I have given you. Does it make sense? Is there anything I need to clarify? Do you want to ask any questions? I wonder if I have confused you. And if you say something like that, then you invite the patient to admit if she was confused and also to ask questions, because you say, actually, it's okay if you were confused. Otherwise, she might feel shy and not kind of tell you that she has been confused by you. So one way, traditionally, people sometimes say to them and say, so now how will you explain this what we have discussed about? How will you explain this to your daughter when you come home, or to your son? And at this point, it's also a good time to explore some feelings about the diagnosis. So how do you feel about this, what we have found? How do you feel about what I have explained to you? What do you think about the treatment plan? So that she has an opportunity to respond to that. Making appropriate management plans is always important, especially in obstetrics, where management plans change and change and change all the time. But equally in gynecology, and after every visit with a patient, there should be a clear management plan. If even maybe it is not yet clear what the patient needs, what management the patient needs, then you state this in your management plan. You say, treatment not yet decided, we'll discuss with head of department and then get back to patient at this and this time, for example. So it is not bad. There's no shame in saying that at the moment we are not clear of what we'll do next, but there has to be a plan about how to find out what best is next to do and when is it going to be done, so that the patient knows about this. If it's a very confusing plan, a complicated plan, then it should be written down for the patient as well. Sharing management options is important. So it is important for several reasons. But the most important it is if the patient shares the management, the kind of treatment plan with you, and then it is hoped that she buys into it and she will follow your treatment better. Because she has made the decision herself, she will also do what was decided. If, on the other hand, you just tell her, this is the best, so you are going to do this, it might not be as might not be a successful management plan for you, or for her or you, because she might not stick to it. She might never get the medication you wrote down for her because she doesn't believe in taking medications, for example. If you have, for example, a patient who has got who's post dates with her pregnancy, so maybe she comes to see you on term, so 10 days after her expected date of delivery. Everything is normal, her pregnancy has been normal, and she has had no problems in her pregnancy. So now the usual and the guideline says you offer this patient induction. But maybe this patient does not want to be induced. So she says she does not want to be induced. At this point, you want to find out why she doesn't want to be induced, and you want to see if maybe you can convince her that induction is the right way and explain to her why you feel that she should be induced. But still, she insists she does not want to be induced. At this point, this is her decision. So instead of kind of being maybe kind of feeling hurt and feeling upset because she didn't follow your kind of advice, you should work together with her, make a plan, say, okay, come back then in 2 days. So you do a CTG, if CTG is normal, to come back in 2 days for another CTG, and again, and you make a plan with her when she should come back and in what cases she should come immediately for any immediate action. So it is okay to let her know if you have a strong preference for any specific management option. But if she goes down another line, you have to find a way to accommodate that and make it work for you and for her. Finally, you have to use appropriate resources. So what I mean is that patients have to be referred appropriately. There has to be sharing of information. There has to be good time management. Also, investigations have to be used appropriately. So not every patient needs all bloods done, but you have to choose what you do and what doesn't need to be done. Specifying an appropriate follow-up time is also very important. So if a patient goes and then you tell her, so come back in 2 weeks and we review your symptoms, or come back in 3 months, or you tell her if your symptoms do not settle down, then wait and see what happens after this treatment. Wait a week. If it doesn't settle down, come back. So that they know what to do. I remember a patient who died in pregnancy. She went to a hospital with a severe headache. And in the hospital, actually, they did a good workup of her. They even did a CT scan. They did, of course, bloods, examined her and so on, and could find nothing wrong with her. So they sent her home and they told her everything is great. Mia min Mia, I have no problem here. So she went home, and this was a Thursday night. On the weekend, Friday and Saturday, she actually got worse. She deteriorated and she developed severe headache, vomiting. She was very bad. But she had in mind, and her family too, that they had said, it's okay. So they waited until the Sunday and went back to the hospital then. At that point, they found her to have meningococcal sepsis, and she died little time later from meningococcal sepsis. So this patient, it's good to you do the investigation. It's good to reassure her, but she should have been explained. If your symptoms do not settle down, then come back and see us again. If they get worse, come back immediately. If your symptoms don't settle down in 24 hours, come back. So you have to safety net the patient, put a safety net underneath the patient so they know what to do in case their symptoms do not settle down or even get worse. Okay, these were the 13 steps of the patient safety consultation model. And I do advise you to use them as many times and practice them as much as you can now in your kind of internship, or also in these last 2 years in medical school. An effective consultation is an important part of a good therapy. It involves an open question at the beginning of the consultation. It needs to have active listening as part of it. Verbal as well as non-verbal communication skills are important. And the language used has to be non-technical and free of jargon. The patient has to be involved in all decisions made. Now, I do have one afterthought to put to you, and this afterthought is concerned with actually your continuous development. It's not only kind of relevant to students, it's also relevant to doctors. It doesn't matter in whose career, it's also relevant to me. All of us have some knowledge that we know. Okay, so this is the known that we are absolutely sure about. So we absolutely know that the blood pressure 120 over 75 is a normal blood pressure. Okay. Then there's some things we know, we don't know that we know them. So the unknown knowns, those are in the multiple choice question, those questions where you think suddenly you're not you're not sure of the answer. Maybe you think a certain answer, but you don't know why you think this answer is right, is correct. Those are the unknown knowns, those that you know, but you're not too sure that you actually know them. There's also some knowledge that we know we don't know them. This is also very helpful knowledge. So this is knowledge that actually you've seen a patient with heart failure today and you weren't sure what the best treatment is or the latest guidelines say. So you know that you don't know this point. So you can go home and kind of educate yourself on that and develop your skills, develop your knowledge. Finally, there's a big area of unknown unknowns, and this is the area that is maybe the dangerous area, and that an area that we should all be aware of, that we should all, because here is our limitations in our skills as doctors and also in our skills as students and also in our skills or in our ability to be a safe doctor. If you ignore that there is a big amount of knowledge that you don't even know that you don't know it, then you will make you might make a lot of mistakes. So this is another kind of diagram to show this. The little circle represents the known knowns, the bigger circle the known unknowns, and those are the this is what we know we don't know, and we can kind of address them. We can make a list and address them. But then there's this big circle of unknown unknowns. And this is the important area where we can always kind of learn and where we should always be open to new ideas and finding out the unknowns that we don't know. So make as many of the unknown unknowns, make them known unknowns. This is the first step and important in our development and in being a safe doctor as well. So what you should do as a student and also as later on in your career is to always keep a list of these unknown unknowns. If you kind of come to realize, oh, I wasn't sure about how we should treat heart failure, so then it's become a known unknown. So you can keep a list and make yourself a point in your to-do list. Read up the latest guideline on heart failure. Okay, I hope this afterthought has helped you a little bit and given you some idea about how to become a safe doctor and how to acknowledge that there's many things you don't know and many things you still have to find even out that you don't know them. Thank you.